Dr. Vaibhav, thanks for joining in. You can also put your camera on and keep the mic off. Are you there, Dr. Kulkarni?
Hey, hi, Ruby. How are you?
Thank you, Dr. Kulkarni, for joining. We have tested the audio video of all the other panelists and we've requested everybody to keep.
Ma'am, we are live now.
Hey, hi, Ruby. How are you?
Hi, Dr. Kulkarni. We are live now. We are starting the session in next 2 minutes.
Not an issue.
Hello? Yes, ma'am, we'll start exactly. Yeah. So once you come on the video, I'll just.
Dr. Prima.
We can start.
Hello. Good evening, friends. On behalf of Indian Dietetic Association Mumbai chapter, I welcome you to this webinar on micronutrient deficiencies in intergenerational life cycle. Friends, we are hosting this webinar in collaboration with HATSA, that is Health Foods and Dietary Supplements Association. I welcome all the office bearers and members of HATSA to this webinar also. We have done this webinar in the nutrition month and we have made it into two parts. First part, we heard Dr. Yagnik, the pioneer. He gave his keynote address on the same topic. And today we have many more dignitaries who've joined us here today for this panel discussion, which will be moderated by Ms. Neeti. So I welcome all the IDEA members and everybody for this discussion. Friends, micronutrients are nutrients that are required in very small amounts, but they are very essential for proper growth and development of the human body. So let's hear on this panel discussion further on this topic by the eminent speakers and panelists that we have today with us. Thank you for joining all of you today. I would now like to take this opportunity of inviting our National President, Dr. Jagmeet Madan ma'am, for addressing the gathering. Friends, she has always been the guiding force for all of us. So I welcome ma'am here. Ma'am, can we please have you?
Uh, uh, Good evening. I can't unmute my video. Can you help me? I've been trying that.
Sure, ma'am.
Yes, ma'am.
Ma'am, you can try now.
Okay. 1 minute.
Yes.
Okay. So very good evening to one and all. It's such a joy and pleasure to see a vibrant IDA Mumbai chapter going strong. And I am so much impressed by their enthusiasm in this, especially in this nutrition month. I think they have done some phenomenal programs on varied topics related to the theme, and also showcase their strength in collaborating with eminent organizations. And today I'm so grateful to HADSA to be our partners. And like what Zamrud said, that, it's the series of, sessions which started with a legendary deliberation and keynote address by none other than Dr. Yajnik, who is an authority, talking about micronutrient deficiency in intergenerational life cycle. And today I am so much delighted to, see Dr. Prema Vartakwi, who's been like, somebody whom I've always looked up to. Excellent endocrinologist and an excellent dedicated teacher from heart, because I've interacted with her so closely. Thank you, Dr. Vartakwi, for being here with us. Dr. Elizabeth, I have so much regard for you, and I've interacted with you even in other forums, and your work is so exemplary. And in addition to that, I think we have Dr. Sadhna Joshi, or I think
yeah, I'm here.
Yeah.
Okay, yeah,
Yes.
Dr. Sadhna Joshi,
Yeah.
from Pune. Thank you so much for being with us.
Thanks for
And,
invitation.
Yes. And Dr. Ganesh Kadam from Abbott is also here. Okay.
Yeah, I'm Dr. Ganesh Kadam.
Yeah. Okay. Ganesh Kadam.
Yeah.
So welcome to this forum, and of
Thank
course
you.
my own colleagues from IDA, Safala Mahadik and Roshan Kore, who have been working with the pediatric population very closely. And I'm so delighted to have my a very elegant colleague, Ms. Neeti Desai, a very experienced person to moderate this kind of a session. And I'm really looking forward to the discussions which will happen during the session. So just setting the tone and the context of what we are going to be talking, I think we are talking about life course perspective. And it's very clear that a life course perspective, has a very sustained kind of an effect. Because if we intervene during the developmental transition, I think the outcomes are really sustained and we can reap the benefits for a longer time. And to my mind, even Dr. Yajnik said adolescence is a very, very right age to intervene. And it's a unique period that gives us the benefit to reap, the outcomes, in this next generation. So, and we know that how important micronutrients are. And we are talking about hidden hunger, and we are talking about the first 1,000 days, and it's so very relevant that we deliberate on this. But on this note, I would like to make an appeal to IDA Mumbai chapter, that it's been very disturbing to hear that interiors of Maharashtra needs volunteers, nutritionists, to save the children, who were probably SAM, and or they were not SAM but have gone into SAM, or the mothers, who need to be made nutrition literate for better outcome. I think IDA Mumbai chapter, it's my appeal and request to you on this forum that we go beyond the urban scenario and we go to the interiors of Maharashtra. Maybe, of course, now is not the time. There are many, many limitations we have, but I think it should be on our radar, that how do we use our manpower, our trained, professionally qualified manpower, collaborating with agencies like UNICEF. I know you had such brilliant session with the ONSAM, where we had people from ICDS, from UNICEF. So I think we can have a more serious dialogue on this, because I feel that we must be there where people need us, right? So that's the mandate of micronutrient, malnutrition. And this was my observation, and I've always felt very at home with IDEA Mumbai chapter. And I feel that I can open my heart and talk to you. That this is what I feel can be the next few steps in the coming times. So thank you very much for inviting me. And every time you make me a part of your celebration, it gives me, it really heartens me, because I have seen this chapter growing for more than a decade, like, nurtured it for more than a decade. And it has really blossomed. And today I see all my youngsters doing such good work. So congratulations to the entire team, Zamrod, Jayashri, Ruby, um, Sukhada, Megha. I think the names are endless and they're so lovely people to work with. And I would always like to praise their hard work. So thank you once again, Zamrud, for inviting me, and please take the session forward.
Thank you, ma'am. We will definitely have this on our next agenda to work on. Thank you very much, ma'am.
Thank you, Dr. Madan ma'am and Zamrud ma'am, for your welcome address and those wise words of wisdom. As Zamrud ma'am said, yes, we will take your suggestions and go to the interiors. And today we have the technology, so even in these tough times, we will work out something to help the needy at the moment. Taking further, let me once again greet everybody, welcome, and a very good evening to all the viewers in India, Tokyo, Dubai, Oman, Myanmar, and Indonesia. To the viewers who are attending from London and Ethiopia, a very good afternoon, and a very good morning to those who are in US and Peru. Well, these are the viewers more than 15 countries who have registered for today's webinar, because this is a very, very important issue. Micronutrient deficiencies in intergenerational life cycle, and especially among children.
Ruby, could you
Indeed,
speak up a little, please?
indeed, it is the need of the hour to discuss, because now we hear a lot of vitamin D deficiency, vitamin B12.
Sorry,
Children are
Ruby.
not taking
Can you
updates.
speak little closer? Your voice is not clear.
Am I audible now?
Yes, yes. Thank you. Thank you.
Okay. Let me put the video off so that I'm much more clearer. Friends, we know that for the fact that micronutrient deficiency is increasing widely in our population due to the shift in our lifestyles and our eating choices. With India undergoing nutrition transition, both the undernutrition and overweight coexist in our population together. And we know this dual burden is a very big problem. of malnutrition, especially in the children of a country where poverty is a very big issue and children are the future of tomorrow. In the last few weeks of National Nutrition Celebration Month, we have been discussing on various issues from different angles, such as the role of nutrition in its first 1,000 days and the importance of breastfeeding. And today, in the last week, it's not the end of it, it is beginning of this subject by all the other experts. Now, let us continue this discussion with the subject experts for which we have gathered here today, where we are talking of the multidisciplinary approach to deal these micronutrition nutrition deficiencies. In fact, I once again thank the Health Foods and Dietary Supplements Association of India. And I think I can see Dr. Vaibhav Kulkarni, who is the Honorable Secretary in this audience. Before we go ahead with today's session with the experts, so can I request you to say a few words so then we can start with the panelists? Dr. Vaibhav Kulkarni, over to you, please. Can you hear me?
Thanks, Ruby. Thanks, Ruby. And um, uh, I would like to really welcome all the Indian IDA delegates, as well as the people who are actually hearing us, not just in India, but the countries that you have been naming in your talk. Uh, I think what let me give a perspective on what is Health and Dietary Supplement Association. So Health and Dietary Supplement Association actually takes up the cause for dietary supplements and health supplement on functional foods part for the industry. We try to we try to discuss the technical aspects on whatever on various subject matters pertaining to this area, this category, and we also try to partner with the government to really come up with the regulations which helps alleviate or to dissipate this some of the issues that are uh, that India is having a problem with. Having said that, uh, as you're aware, micronutrients are so important in our body. So micronutrients, you know that uh, it includes vitamin, minerals, and your phytonutrients. They're so much important uh, to your body uh, for the functioning of body and brain. Yet the saddest part is you cannot make it inside your body. Most of them you cannot make it. Also, they people tend to concentrate more on micronutrients. Of course, it is important. It requires in the larger quantities. People do concentrate more on these nutrients rather than micronutrients. I mean, you will find a normal person talking about, oh, how much protein you take, how much carbs you don't take or take, but none of the people I've heard, or many or less amount of people when you talk do talk about how much calcium or magnesium or so on and so forth, that and that is so important, because even in small quantities, but it is required because it helps in the working of the nervous system, to the immune function, and to the bone strength. So looking at these aspects, I would say this entire thing is so important. uh, this entire issue is so important. That's why we did in this two series, because one, we did it on Friday, which is having a subject matter expert, Dr. Yagnik, uh, talking about his research um, at that point, and we were planning to do it on the same day, but it would have been a little bit heavy. And so I thought the web series that we actually the idea that probably idea gave me or us at Hatsa was really a good idea, and we took that idea, and I think this is what we are going with. So again, once again, I welcome everyone. I think this. I hope you will gain a lot of stuff from this panel of experts that are there, or the batteries of experts in their field. And we will really enhance that. This will really enhance your knowledge about micronutrients. And I hope you have a great session. Thank you. Over to you, Ruby, again.
Thank you, Dr. Webber Kulkarni. Well, no other day can be better than doing the session today, because today only we have all received the new RDS 2020. And of course, whatever we discuss today can be deliberated upon once again. So, taking no further time ahead, I request the co convenor of this program, Ms. Megha Terse. She is the executive committee member of IDA Mumbai chapter, to take over from here and invite the moderator of the panel discussion. Megha, kindly take over from here onwards. Thank you.
Thank you, ma'am. Good evening, everyone. So this expert panel is being moderated by a very own Neeti Desai, ma'am. She's a consultant nutritionist practicing in South Mumbai. She's also attached to a Kambala Hill Hospital since 17 years. She's secretary in Association of Diabetes Education, co-editor of IDA Clinical Dietetic Manual, a joint treasurer of IDA Mumbai chapter, and a regular columnist in Health and Nutrition Journal. So and she's also an official nutritionist, Femina Miss India in 2008. I request Neeti ma'am to kindly take over the panel discussion.
Thank you, Megha, for the kind introduction. A very warm welcome to the HADSA members and, of course, our dear colleagues from IDA from different parts of the world. It is very heartening to see that. Um, we are session number 2, and if we have to follow Dr. Yajnik, that is a very tough act to follow. But here we have a panel of, in fact, a galaxy of very eminent faculty from different specialities to take forward the discussion and deliberation on the subject. So it is my absolute privilege and pleasure to introduce the panel. So can I have the slide, please? We have very own Dr. Prema Vatakvi, who has been at one of the premier Mumbai medical colleges. She's an emeritus professor there, and her research interests lie in diabetes, thyroid, and reproductive endocrinology. She has an immense research experience, as she has 95 peer-reviewed publications and 75 presentations in various conferences. A very warm welcome to Dr. Prema.
Thank you, Neeti. Thank you so much for inviting me. Pleasure to be with you all.
The next panelist that we have is a very senior pediatrician, Professor Elizabeth. She is the professor and HOD of pediatrics at Sri Mukambika Institute of Medical Sciences in Kerala. She was the past IAP president of the Kerala chapter. She was also the national president of the nutrition chapter of IAP. That itself shows her keen interest in nutrition. Of course, she has delivered many orations, and she's been the recipient of multiple awards: Best Actor Doctor Award from Government of Kerala, M.O. John Memorial Best Publication Award from IAP, Dr. Karunakaran Award, and Dr. Krishnan Award. She has authored many chapters in national and international books on nutrition and child development. Again, a very warm welcome. We are privileged to have you, Dr. Elizabeth.
Thank you very much. I'm really honored to be part of this.
Namaskar, Dada. Sir. Hello.
Yes, can we have the next slide, please? Yes, it is heartening to welcome our colleague, my colleague from Mumbai, Roshan Kore. She has been a pediatric nutritionist for years now, having worked in some of the most esteemed institutes, such as BJ Wadia Hospital for Children, and now she's at SRCC Children's Hospital in Mumbai. She has been very active on a Keto Kit project, which provides ketogenic diets for treatment of children with epilepsy. And she, in fact, also is involved in rural camps for underprivileged neurology patients in rural Maharashtra. Dr. Madan would be very happy to hear about your work. She's been doing this since last 10 years. A warm welcome, Roshan.
Thank you very much.
I think the slide is slightly
Ma'am, can you see the slide?
the slide is not, no, it's not properly aligned. Dr. Ganesh Khade, again, is an alumnus of BYL Nair Charitable Hospital, Mumbai boy. He has 20 years of experience in clinical operations. And at the moment, he is the Associate Director of Medical Affairs with Abbott. Dr. Khade has covered many geographies from India to Latin America, and he has conducted lots of clinical studies and in fact patented 15 molecules in India. So he comes with tremendous industry experience. A warm welcome again, Dr. Ganesh.
Thank you very much, and best regards to the all honored panelists. Thank you very much.
Dr. Joshi.
Some technical errors, so I'm not able to display Joshi ma'am's screen.
Right. Okay. A very warm welcome to Dr. Joshi. Dr. Joshi has, again, over 25 years of experience. She's a director grade scientist, and she heads the child and nutrition department at Isha in Pune. Tremendous research work and absolutely original work. She is on task force of many governmental organizations. She's on the editorial board of Journal of Nutrition and Intermediary Metabolism. And she's also a reviewer of many international journals, having guided 16 PhD students so far. She has been awarded the Research Excellence Award for Developing Country Scientists at the 7th World DOHAT Conference, and indeed an achievement. A very warm welcome, Dr. Joshi.
Thanks, Neeti. I really enjoy being part of you all. It's indeed a great honor for me to be part of this meeting here.
Thank you. And last but not the least, our very own Safala Mhadek. She is an active member of our Mumbai chapter and a very senior dietitian with over 32 years of experience, having worked at one of the largest medical facilities in Mumbai, that is KM Hospital. Pediatrics has been her interest, and she is going to give us a perspective on the public health, her experience in public health hospitals. She has, of course, covered a lot of interviews on Doordarshan and has had a series of talks on All India Radio. A warm welcome, Safal. Yes, and of course, she's an RD trainer as well. She's training the next generation of dietitians. How can I forget that? Right. Okay, so to begin with, as we've understood, micronutrient deficiencies is also referred to as hidden hunger, and it affects the health, learning ability, as well as productivity, contributing to a vicious cycle of malnutrition, underdevelopment, and poverty. In fact, one of the biggest learnings that we had from Dr. Yajnik's lecture over the weekend was that micronutrient deficiency, when it comes to women, does not affect one person, but in fact, it affects 3 generations of women. And it has been projected that these micronutrient deficiencies can cost around 2.5% of the GDP of the country. So it's a huge problem. All said and done, India has made tremendous progress with several programs and schemes such as ICDS, midday meal program. And when it comes to, again, micronutrient deficiencies, we've had our National Iron Plus initiative, we have had National Iodine Deficiency Disorders Control Program, and National Prophylaxis Program against nutritional blindness due to vitamin E deficiency. However, still a large part of the population suffers from micronutrient deficiencies. While anemia continues to be the most common indicator of micronutrient deficiencies, the iodine deficiency and vitamin A have improved, status have improved over the years. But now we have the additional challenges of vitamin B12, vitamin D, and maybe in the COVID scenario that we are in, even zinc deficiency needs to be looked at. Since we are going to be talking about intergenerational life cycle, let me start off with children. And if I can start asking my first question to Dr. Elizabeth, the eminent pediatrician whom we have on the panel. Dr. Elizabeth, in your 30 years of experience, which is the biggest and the most common nutrition challenge that you have observed? And have the challenges been different or have they changed over your years of practice?
Thank you, Nidhi, for that very interesting question. Actually, what I'm seeing, the most pressing problem is that I'm not seeing many normal children these days. Normal children are decreasing. The double burden is increasing, and in fact, it is a triple burden, the micronutrient malnutrition also. There are a lot of stunted children, wasted children, and similarly overweight children. And the NFHS 3 to 4, we have not made much progress. We can see that still we have 38% stunted, 21% wasting, and so on. And I believe that every child who is born has the right to good nutrition and to quality of survival. But I see most of them getting malnourished because of nutritional and environmental problems, and many more are going to the other spectrum, that is overweight and overnutrition, overweight and obesity. The challenges have been different over my years of practice. 3 decades back, I was seeing most of stunting and wasting, kwashiorkor, marasmus. But at the turn of the millennium, the transition started from the marasmic to the obese. That is because of the nutrition transition that was being referred and the socio-cultural practices. Now I see that 20 to 30% of the children are overweight or obese, 10% are underweight, and many more are stunted. And over 40% have micronutrient malnutrition, which is often hidden, but sometimes it is overt also, like anemia, then folate, B12, as everything was spoken. And it is very sad that in the global hidden index, which is the sum total of iron, vitamin A, zinc, and iodine, that we have at 34 percentile. That means 34% of our Indian population is having the hidden, global hidden hunger. That is what is seen. And so we are at a very serious part of the problem.
Right, ma'am. So as you mentioned, we have now not double whammy, but triple whammy here that we have to kind of face, encounter, and treat. The second question goes to the pediatric nutritionist on the panel. It's for you, Roshan. In private hospital setting, which are the most common micronutrient deficiencies that you see? And what are the signs and symptoms that you look out for? And what blood tests that you advise most commonly?
So thank you, Niti. So we all know that the food consumption habits of children, especially in the upper socioeconomic strata, has changed during the last few decades. And they now consume too much of fat, especially the saturated fats and sweetened beverages. They do not eat enough fruits and vegetables and consequently do not consume enough fiber. Most children consume less milk, less vegetables and fruits. A study showed that only a fifth of the children consume the recommended daily amount of fruits and vegetables. Hence, multiple nutritional deficiencies, including iron, calcium, zinc, folic acid, and vitamin B12, C, D, and E, is seen in hospitalized children nowadays. So the signs and symptoms, like we are all very familiar. Like for iron deficiency, you would see the problem with iron deficiency, as we all know, is that initially it goes unnoticed when it is mild. But as the body becomes more and more deficient and depleted in iron, anemia worsens. And then the signs and symptoms that you could see would be extreme fatigue, weakness, children coming home after play or refusing to go to play, being tired, pale skin, chest pain or fast heartbeat and shortness of breath, headache, dizziness, lightheadedness, cold hands and feet, inflammation or soreness of the tongue, brittle nails. So these are some of the symptoms of iron deficiency. In calcium deficiency, there is usually numbness, muscle cramps, poor appetite, lethargy, weak fingernails, nails that tear very easily, easy bone fractures. So we get a lot of patients coming with bone fractures, basically because of calcium and vitamin D deficiency, and that is when it gets diagnosed. If we talk about vitamin D, there is weakness of muscles and muscle aches and pains. And again, here it may go unnoticed. And the main reason is basically because the children are not exposed to enough sunlight. Zinc is one more deficiency which is seen and may be difficult to find out because it is predominantly seen in patients with malabsorption or with poor dietary intake. Also, zinc deficiency can lead to poor appetite and weight loss. The child will have recurrent respiratory and gastrointestinal infections or problems, which can further elevate all the multinutrient and zinc deficiencies. Vitamin B12, as we see a lot in our patients because we get a lot of patients who are either vegetarian or who eat a Jain type of diet where the plus the level of cleanliness or hygiene is extreme. Hence, there is a lot of B12 deficiency seen. The symptoms could be tiredness, fatigue due to megaloblastic anemia, and there could be increased chances of bleeding and getting infections. In infants, it can also cause a unique neurological condition called infantile tremor syndrome, in which the child gets tremors and milestones can be lost if the condition is prolonged. When it comes to testing, mostly the common test we would tell would be a CBC to get the read on the hemoglobin levels. If the doctor is suspecting any specific multivitamin, normally the level of the vitamin may be done, would be like vitamin B12 or vitamin D. The levels, blood levels are normally checked, and then accordingly the medicines are prescribed.
Right. I would like to ask the same question to Safal. In the public hospital setting, Safal, what are the most common micronutrient deficiencies that you see? Are they kind of the same ones that Roshan elucidated, or you have a different take? And again, are there any different signs or symptoms that you see more commonly?
Yes. Can you hear me?
Yes.
Yeah. Yes. The micronutrient is basically, we can say, umbrella term, which represents all essential vitamins and minerals. So when we say all this, then basically all these vitamins and minerals, what body needs, it body cannot synthesize it. So when it and it's really required to sustain all cellular and molecular functions of our system. So and MNDs usually come in multiples and along with malnutrition. Now, malnutrition, as Madam said just now, that it comes in overnourished and undernourished. We have seen both the type of children and as well as in pregnant women, because these are the two more vulnerable groups. So I have seen the MNDs like the same way this one Roshan said, vitamin B12, calcium, magnesium, and iron deficiency, vitamin D, along with inflammatory markers like protein, albumin levels are low, the CRP levels is high. So these are the main markers which we see along with these MNDs, because MNDs usually come in multiples. So in this, like for obese children, for example, if we see, then obese children, they have more of refined carbs and excess calorie consumption, whereas they are lacking in all the sprouts and fruits, vegetables and fiber, all this. So they are definitely they are lacking in micronutrients. Same and undernourished children, where they are lacking in both, deprived of macro as well as micronutrients. As we are talking about intergenerational cycle, here we have seen the pregnant mothers also, with especially from the lower socioeconomic class, where they have multiple pregnancies, and then in the past, and their own nutrient maternal stores are already declined. And in that condition, when there is a myth about food, lack of nutrition, poverty, unhygienic conditions, there are so many psychosocial elements also. So along with that, there they when they give birth to a child, usually they preterm babies or low weight babies are born. So this is what we see in intergenerational cycle. And same way, we find pregnant women with they look healthy, and they are obese or overweight, but still they have deficiencies of this micronutrients, and because they are lacking in the this nutrient dense foods, but they are having unnecessary the excess calories through refined sources. Now, as you said about signs and symptoms, there are again in if we say about pediatric population, when hospital setting, when patient comes with acutely ill undernourished children, they come with varied symptoms. They come with the varied symptoms like severe dehydration,
Thank you so much
anemia.
for sharing the paper. Now, I'm a little stuck. First of all, tell me how much is the cost of this supplement?
Hello.
Carry on, Safal.
Yeah. So when we get acutely ill undernourished children, they come with varied symptoms like severe dehydration, anemia, fever, failure to thrive, hypoglycemia sometimes, acute respiratory infections, or even sometimes rickets or pitting edema. Now, in this case, I'll see signs and symptoms in a different perspective, as Roshan already said about micronutrients and their signs. Here, I'll say that when they come with this new deficiencies, like suppose, for example, if they come with a symptom of dehydration and marasmus, then what happens is patient comes with a pale skin, weak pulse, sunken eyes. The face is like old person. Then lack of alertness, cold peripheries, and no tears when they cry. So there are failure to thrive. There are so many symptoms they get. Even pitting edema, if we see, then there also we have seen three grades. The edema in the ankle and feet, sometimes with the legs and feet, and in the severe conditions, it is all over the body, like including the face and even the hands. Also, we see there is we find edema. Same way in the rickets, we see with the knock knees and bow legs, very lethargic symptoms. So every symptom comes with the different signs, and every child comes with a variety of symptoms. As you said about second part of our question, last, that is a blood test. What you said. See, there are this stays like B12, zinc, and vitamin D. It's with a low less resources. It's not mandatory to do this, but yes, the routine metabolic panel is definitely done. Like CBCSR, RFT, LFTs are done. Prothrombin time, all markers of inflammation are usually taken along with RFT, LFTs, and protein, albumin, and all that. That those things are done, and I'm very proud to say these physicians, like clinicians in the hospital, they minutely observe so well these children, and they diagnose very critically well. And then without doing this, this test like B12 and vitamin D, they diagnose correctly. And along with that, when we do nutritionally assess correctly and do intervention, then we can definitely treat them without doing all this additional tests which are not possible at the our hospital setting.
Right. So I think that is the very important message, that in limited resource setting also, if the clinical acumen, even for the dietitians, nutritionists, if we are more aware of the clinical science, we don't always have to go for the expensive battery of tests. Yeah,
Yes,
thanks,
yes.
Safal. Uh, Next question is for Professor Elizabeth again, since we are on pediatrics children still. So I was going through your work on nutritional deficiencies in CP patients. In fact, you worked on micronutrient deficiencies in children with special needs. So your experience on this population, please.
Yes, we have been working with some children with cerebral palsy, the nutritional challenges and deficiencies, and we have published that also. You know, most of the time it is very difficult for the mother to feed the babies, these children. One is because of their disease. Second, they are very poor. Most of the time they are abandoned also. Nobody wants them because when the children are sick, many families, the mother and the child is usually abandoned. So that social problem is also there. What we have seen is that they have problem with dentition, with their gums, or the hygiene part of the mouth is very poor. Then they have so much of spasticity that they cannot swallow. They have chewing and swallowing problems, and then the gag reflex is more, and the the oropharyngeal coordination is less. Then gastroesophageal reflex. We see that in babies, but as they grow bigger, by 1 year or so, most of them get over it. But these neurologically abnormal babies and children with Down syndrome and all continue to have the gastroesophageal reflex. So they have choking spells when they are fed. And then because they are on anti-epileptic drugs, and most of the time bedridden and indoor, lot of vitamin D and calcium issues are also there.
Right. So I think when we are talking about children with special needs, it needs to be a multidisciplinary approach where we have a pediatrician, maybe a speech therapist, an occupational therapist, and a dietitian involved, so that we can devise the plan properly, which also looks into the texture of foods, not just the nutrient, but also the food texture, because then only it will be possible for the patients to, for the children to take it in.
Exactly.
Right. The next question is for Roshan. Since you've been conducting many rural camps since the last 10 years, Roshan, which micronutrient deficiency is most pronounced? Of course, we are talking about Maharashtra in particular. Any cooking practices or dietary habits that lead to enhanced loss, or is it just the primary problem of inadequate calories?
Yeah, Niti, the rural camps that we do are predominantly the pediatric neurology camps. So all the children are having some or the other neurological problems. So the deficiencies are absolutely similar to what Dr. Elizabeth has just mentioned. But what I can say more about it is that when we started the camp for the first 6 years, we did a survey of the nutrient intake and the signs and symptoms for malnutrition just to assess what is the nutritional status of these children. And along with the patients, we knew that a lot of patients come along with the siblings. So we also did the nutritional assessment of the normal children. And we found that vitamin A, D, iron, calcium, zinc, the B complex vitamins, and B12 is deficient in the patients very much, but it is also present in the siblings. So coming to the second part of your question about the dietary habits or practices, we found that it is more to do with the poverty, which leads to malnutrition because there is inadequate food supply to these people. They come from a very remote rural background. So we have two types of patients coming from the rural background as well as those coming from around the Nanded city. So these problems were very much predominant in the rural population. And the main reason was that they were getting inadequate food intake, leading to calorie, protein, and micronutrient deficiencies. Also, the most important reason was that there is a lack of diversity in the diet. The staple food being just jowar or wheat roti and sabzi. And this is what they eat 3 times in a day. The diet is very much lacking in milk, non-veg foods, pulses and legumes, and all kinds of vegetables. Fruits is scarce. So it is more about the socio-economic status of the patient rather than the cooking practices. However, we also feel that, like my friend Bhakti Turaskar, who is also involved with this camp project. So what we always discuss is that it is something like an intergenerational influence where a mother who is not aware or not intent on using different kinds of food in the household influences the daughter, who in turn, when gets married and goes to her family, carries the same thinking and does not include diverse food in the diet. So what we do here is basically we do a lot of education during the camps. So extensive counseling and education goes throughout the day and night when the camps are going, so that we reach each and every mother and daughter and family member who are present on the campsite. We teach them to methods of cooking, where we say that you wash the vegetables first, then you cut it, or cook it with a covered, or cook it on with steam. Do not add too much of water. Do not overcook the vegetables. So the basic nutrition principles we try to teach them in the local language that they understand. We also tell them we tell them to use the locally grown seasonal vegetables and fruits. So whatever vegetables, fruits we see in cities are different from what are grown locally. So we ask them what is available in your areas, and we tell them that this is very cheaply available. It is available behind your house. So please use those vegetables. What we also do is we do a blanket micronutrient supplementation for these patients. So for the neurological patients, we give a mandatory vitamin D once in a year. We give calcium biannually, because our camps are held biannually. We give iron, especially we give iron even to the siblings if there are girls, or especially the adolescent girls. We give B complex syrups. We give zinc for a period of 7 to 14 days, and ask them to continue the zinc syrup whenever they have fallen sick. And we have observed that after doing this over the subsequent period of 10 years, the recurrent GI and respiratory infections have really decreased in this population. Also, we do mandatory deworming, and we do this for patients, siblings, and the whole family. So we do not treat only the patient because it is useless. We do treat the whole family. And as part of the nutrition program, we have also taken up one more project. The Kamal Udvadia Foundation, who is the project, the ketogenic, the whole camp goes under the Kamal Udvadia Foundation, and they, along with the Swayam Shiksha Prayog, which is a NGO based in Pune, are doing a project in Nanded area, where they have enrolled women from the local communities. They are called Arogya Sakhis. So these women are training local women to grow crops. What they call is ran bhaji. So the crops that are, or the vegetables that are grown in the local household area, or what we call a kitchen farming. So this is something that they are promoting. They are taking the message that we give at the camp on a day-to-day level to the grassroots level. And that is how we are aiming to reach to this or treat this problem that is present in the rural areas.
Amazing. It's a commendable and exhaustive kind of 360-degree approach. So besides food security, the food diversity, and as we know that when you teach, educate a woman, you educate the family. So that is kind of really being put into practice. Excellent, Roshan. The next question is for Dr. Joshi. I did see that you've done immense work on preeclampsia in pregnant women. We are moving up now from children to adults, and that maternal micronutrient imbalanced diet has adverse effects in pregnancy. And in fact, vitamin D may have an important role to play in this as well. Now, also in this COVID scenario, vitamin D is, of course, a very strong protective, has a very strong protective role. That is what is coming out from serious studies. I have a question. In the urban settings, post-lockdown, with reduced pollution levels and air quality index improving, does it make sense for us to encourage our patients and people, general public in large, to be in the sun As in pre-lockdown period, exposure to sunlight did not make any difference in this, I'm talking about urban settings, due to very poor AQI. And your take on this, Dr. Joshi?
Yeah, thanks. I would just like to draw your attention to that we have been working on micronutrients like folic acid and vitamin B12. And yesterday you have heard Dr. Yadnik say that S-adenosyl methionine is a major methyl donor. So we are focusing that if this is the major methyl donor, there has to be a methyl acceptor also. So the methyl acceptors are phospholipids, and the long chain polyunsaturated fatty acids are mainly transferred to the body via the phospholipids. So our major focus is the omega-3 fatty acids or the long chain polyunsaturated fatty acids. Like we've been hearing a lot of talk about deficiency of vitamin B12, but I would also like to draw your attention to that due to rapid industrialization, what has happened is to increase the stability of oils, there is a lot of incorporation of the omega-6 fatty acids. So that results in an imbalance of the omega-3 and the omega-6 fatty acids. Right, in ancient times, it used to be in the ratio of 1:1. And the recommended ratio, maybe it could be 1:5 or max 1:10. What you currently see now in pregnant women is 1:25 or 1:30. So this much of an imbalance that it has caused. And also we know that the omega-3 fatty acids, they lead to a different pathways which are anti-inflammatory in nature, whereas the omega-6 fatty acids are more pro-inflammatory in nature. So the moment the balance between the two is lost, it can trigger inflammation and also, result in maybe a lot of COVID kind of situations also, because recent studies have come up on that. Now, to understand the better effects of this, the Indian Council of Medical Research has granted us a Center for Advanced Research to mainly examine how these micronutrients like folic acid, vitamin B12, and the long chain polyunsaturated fatty acids right from early pregnancy, they influence the risk of an adverse outcome. So what we do over here is we are recruiting women right at the beginning of her pregnancy at the 11th week of gestation. We're following up the woman right across pregnancy for different time points. Then the child at delivery, again, blood sample, placental samples are collected, and the child is followed up until 2 years of age to assess the neurodevelopmental risk. So in addition to these micronutrients such as folic acid and vitamin B12, which are components of the one carbon cycle, we have also shown that vitamin D also interacts in this one carbon cycle because it is associated with increased oxidative stress and thereby also influences the long chain polyunsaturated fatty acid metabolism. So as you can see, it is not a question of just targeting one particular micronutrient. We have to have a holistic view while we are addressing these issues. And deficiency, we have shown that deficiency of vitamin D is associated with increased risk of preeclampsia in our cohort, especially in the higher socioeconomic group, where, as you said, there is limited exposure to sunlight is there because most of them come from the higher socioeconomic. They're IT women who are hardly ever exposed to any kind of sunlight. And the foods that are rich in maybe omega-3 fatty acids are not there. Another problem with the omega-3 fatty acids is that it's mainly the DHA, which is the main molecule, is found in non-vegetarian sources such as fish. And consumption of fish is very limited in a vegetarian scenario. So what happens is if you rely on the vegetarian sources like walnuts, these are very expensive. So and the conversion further is also very limited. It's hardly 3 to 5% conversion. So you will understand how complex the whole scenario is with all these micronutrients interacting with each other. It has to have a very kind of a balanced diet that's there. And now to address your question of whether sunlight exposure, I would say yes, definitely. Without, of course, having to go out into, a crowded environment in your own complex, on your terrace. I feel each and every one of us must have some kind of an exposure to sunlight because that is the best way to improve your vitamin D status. And a recent study from Boston has shown that vitamin D does influence the recovery rate of these COVID patients. So literature is still coming up on that, on the role of different micronutrients, but there is no two thinking that the micronutrients such as vitamin D or the omega-3 fatty acids play a very important role in managing the inflammation which is there and possibly will help, a better recovery of these COVID kind of scenarios.
Thank you, Dr. Joshi. Yes, so we cannot, it has to be a holistic approach. We need to address all the issues.
Correct.
Next question is for Dr. Ganesh. So on the day when we've received the new guidelines, RDA 2020, I would still like to ask that, is that a concern that we do not have Indian RDAs for many micronutrients and we rely on US RDA or the WHO guidelines? From the
Uh,
industry point of view, is that a big concern?
Sure. First of all, before I approach your question, let me just bring to for the audience. Let me just explain that being in industry almost for more than 2 decades now, I definitely got a good perspective or different perspective, and I'll try my level best to bring that perspective, which will be interesting and useful for all of you. Coming to this question, RDA for Indian RDA and say the global or Western RDA. Here, what we need to understand first of all is how these RDAs are derived. Basically, so there are four factors generally are considered for RDA definitions. The first one is the EAR, that is estimated average requirement for particular health conditions. So to define the EAR, the a particular health benefit is defined, and that health benefit is correlated with some of the biomarkers in the body. It may be a serum concentration, urine concentration, or so on and so forth. So that is a crucial thing in defining the RDA. And then that once we have a ER value, that is actually then multiplied by your various kinetic, the pharmacokinetic absorption covariance, or maybe a body loss. What are the body loss in terms of metabolism and excretion from the body? And lastly, it is the whole this thing is further multiplied by the value of intake, population intake. So it may be a mean, or generally those two standard deviations are taken to cover the broader spectrum of the population, because RDAs are meant for almost 97.5% of the population. So this is, if these four factors we consider, the EAR, then absorption viability, and then the body losses and the population intake. The two factors generally are actually a lot of variability is there. There's a lot of confounding. One is the EAR, and the last one is what is the population intake in your country. When we apply this basic principle and apply this to the RDA, defining the RDA, I'll just explain you, and I'll consider four examples. The two examples are generally for the RDAs where the Indian RDAs are not in line with the global Western RDA, or maybe the available science, and a few ingredients where the Indian RDAs are sufficient. The modeling is done in a good proper way, because definitely the data is available, because for everything data has to be available. The first example, as we all talking about vitamin D, actually, if you really see calcium and vitamin D, the Indian RDAs are basically are focusing on the musculoskeletal benefit of vitamin D, that is the EAR health benefit, and they are correlated with the serum concentration of 20 nanogram per deciliter. Now, when we just consider this as a benefit, then definitely your RDAs will suffice your musculoskeletal benefit. But as we know that vitamin D has a lot of health benefit beyond musculoskeletal benefit. A lot of meta-analyses have shown that the vitamin D is useful in various other metabolism, as Dr. Sadhana said, one carbon metabolism, or maybe a cardiovascular benefit, all-cause mortality benefit. And when we consider that benefit and correlate with the serum level, it goes to around 40 nanogram per ml. And this serum level, if you consider all your absorption kinetic, vitamin D doesn't have much of absorption, because it is synthesized in the skin, and your body losses, which is standardized all across the globe. There is not much of ethnicity differences across the globe. And the population intake, if you consider that, that's why we are landing on much lower concentration RDA values compared to the global, because global are focusing beyond musculoskeletal benefit. This is one example. Second example, if you see where we are not in line with the global science or the global recommendation, is vitamin C. Now, if you see, vitamin C is very relevant in COVID condition, because all the prescriptions generally are definitely vitamin C, high dose of vitamin C. India has approached India and UK. If you really see, these two countries have approached vitamin C RDA with a midpoint of the level required for scurvy prevention and the level required for complete body saturation. So scurvy prevention require 300 milligram. For complete body saturation, require around 1800 milligram, and we are taken 800 to 900 milligram as a EAR benefit to just to prevent the scurvy. We calculated that, and with that calculation we arrived at 45 milligram per day. Different countries and with various benefits of vitamin C, actually now very well established, different countries have taken a really interesting approaches. For example, IFSA and DASH countries, actually they are saying that with the safety margins of vitamin C, just targeting 50% of the body saturation, tissue saturation may not be helpful. Let's target for the complete body saturation, and they are targeting actually 1800 milligram, which is getting reflected to 90 milligram per day of RDA for vitamin C. US and Canada has taken further a different approach. They are actually talking about the immunity benefit of vitamin C, and they have actually calculated the erythrocyte calculation, not erythrocyte, neutrocyte, neutrophil concentration, and with that saturation kinetic, they have arrived at 90 milligram to 110 milligram of vitamin C. Japan, China, and the Korean countries and Nordic countries for that matter also actually they focus on the cardiovascular benefit of vitamin C. So what I'm saying here is we have to understand what is the ER health benefit we are talking about and its relevance from the Indian point of view. So these are the examples where India, I think the modeling has not done well, maybe because of the lack of data. But definitely credit to us and our scientists and for everybody, all the stakeholders in this. We have done fairly well in iron, maybe in vitamin A, iodine, we are done very well. Zinc, definitely we are at par with the global science because global RDA is also equal. But considering the Indian need and the high prevalence of diarrhea and the respiratory disorders, because there is a direct correlation, very well established correlation of zinc deficiency and diarrheal mortality or mortality because of the respiratory diseases. So although we are 20% more than the global RDS in zincs, I think still there is a headroom because it's a low hanging fruit. If we really act well in zinc, I think we definitely it will have a major health benefit. So just to summarize and to answer your query, there are ingredients or micronutrients we have done well, and they are actually because of the data all four components are done well, and we can refer to that like iron, as I mentioned earlier. There are ingredients, ingredients where we still need to fix our values well, and doing so we can definitely refer to the Western world or the other countries, but while doing so we have to consider what health benefit they are talking about and whether that health benefit is relevant in Indian context.
Thank you very much for sharing your global
Yeah.
view on the RDAs. That was really useful. Next question is for Safal. Compliance. When we talk about compliance to folic acid supplementation during first trimester. Do patients come in for preconceptional counseling in a public hospital setting where there is opportunity to start folic acid earlier? You're muted, Safal.
Now you can hear me?
Yes.
Yeah. Yeah, good question, Niti. So majority of the times we have seen the females, especially from the lower socioeconomic class, when they don't come and see endocrinologist or gynec and nutritionist unless and until they are having any problem, irregular menses or having any infertility issues or PCOS or sudden weight gain, something on that kind, and they come to hospital. So this group, when they get conceived, maybe sometimes first month or after second month they come and meet gynec and as well as to us. But that time that one first the main crucial period is missing. So that is also we observed, and then the folic acid doses gone because they come late to us. Those are already under some treatment and they come regularly, and those then we advise them supplementation. The second extreme also I have seen, those are from the good class, they are well read on health sciences and all that. That part of that, those women also are there. They start folic acid supplements right from say before they just think of conceiving or 1 6 months or 1 year before, and usually they are on Folvite and they say ki, yeah, we are taking Folvite, so maybe 1 year more before conceiving. That also picture we have seen, as that day Yajnik sir said ki then they are 12 times taking more of folic acid. So that also I've seen picture that they are on 5 mg for more than a year. So such people also are there, but the majority class they come late after conceiving when that period is gone. So unfortunately, for such preconceptional counseling, we get less opportunities to start folic acid earlier. Sometimes when we take some small group sessions in some time, some seminar or something of that kind, where we all gather all such females, all pregnant women, or those are three, but that comes very rare chance, once in 6 months or something. Then that time we explain them in depth about nutritive real values and nutritive Indian foods, which are simple, and then they know it really very well, but they don't know how to use it, because many times it happens that simple cereal pulse combination also gives you good nutrients, macro as well as micro, but they don't know about it. So this we get chance to explain them when they actually be taken in a group sessions, but that comes very sometimes, it's
It's
not
rare,
regular.
yes.
Yeah.
Yeah. So I think the important message here is that, generally we think that folic acid is a water soluble vitamin, so there is no issue. I mean, you can take it forever or take it for a long period of time. But as Professor Yajnik explained to us, that excess folic acid has issues with adiposity and whatnot. So I think we need to, as a fraternity also, we need to be more kind of clued into this and advise patients
Yeah, because we
accordingly.
are getting it over the counter. This B12 or B folic
Yes,
acid, this capsule are getting. So they don't come and ask physicians, they directly start.
right. Next question is for Dr. Joshi. You did talk about omega-3. So should omega-3 intake in pregnancy be encouraged through dietary sources, or a supplement would lead to better compliance and outcomes?
Yes, omega-3 fatty acids, I would say one should have adequate stores preconceptionally, not necessarily only after she conceives, because if she has, studies have shown that adequate stores of omega-3 fatty acids like DHA definitely improves the pregnancy outcome. Of course, food sources are the best thing that one should do, but in the given scenario, that especially in Indians, since we are so much deficient or depleted in the stores of omega-3 fatty acids, a low dose supplement would be preferred, which you can start preconceptionally and carry on across pregnancy. I would not recommend a high dose, because if there is high amount of omega-3 fatty acids, it increases oxidation, and that may again cause a different kind of a problem. So it has to be a low dose supplement which can be taken.
Great, thank you. Thank you. Next question is for Dr. Ganesh. Indian population has, of course, a very high incidence of nutritional anemia, uh, low iron intake. From the industry point of view, any ideas to address this extremely prevalent and chronic problem?
Yeah, okay. Interesting question, and thanks for raising this, because these are the platforms where we can definitely share our views. I'll just set the context what I'm going to talk, because here industry, I'm not going to talk only restricting to nutrition industry or nutraceutical industry or the pharmaceutical, because they are not only the players who are making a difference in that, but there are many other sectors or industries also which are playing important role in this. Second context we need to understand is iron deficiency, iron, let it be iron source, iron content in Indian diet, heme or non-heme portions of the Indian diet, their absorption, and then their storage, utilization, and so on and so forth. It's a very complex system, and there are many factors, and many confounders they play a role in overall iron metabolism and its function and its effect on the body. So fixing it by one stakeholder is definitely may not be a good idea. So many things are happening in this context. Just to simplify this, I'll just classify this into the three broad domain. One is the R&D, the various types of research and developments are happening in there. The second domain where industry or the various industries are playing important role is the policy making or the policy decisions and shaping up the protocols. And lastly, but not the least, is awareness and viability of the various options. Of course, as I said earlier, it doesn't happen singly. We always collaborate with the various stakeholders. Coming to the R&D, the molecular R&D, as we all know that currently we rely on for the diagnosis at the individual level, also at the population level, we mainly rely on hemoglobin concentration. Rarely we do a serum ferritin or total ion binding capacity markers. But there are various good biomarkers which are coming up. These biomarkers are showing very good correlation with the not only with the current anemia status but also with the iron deficiency status and the erythropoiesis status. These markers like zinc protoporphyrins or the hepcidin ratios, or maybe the serum transferrin receptor to hepcidin ratio, these are actually getting set up. They are getting validated, not in the only in the clinical studies but also in the pilot population surveys and the population studies. Further, there is a lot of research. All the diagnostic companies are doing a lot of standardization of the test, because we all know that the iron deficiency, the different lab, there's a lot of variability in the lab, especially in terms of the hemoglobin and the ferritin concentration. So we need to standardize all these laboratory together. There are 2 3 major kits used, one from Roche or maybe from Lima laboratories across the globe, also in India. But definitely the standardization of all the kits are needed when we are talking about or when we are making country ready for a major intervention. So that standardization of the various parameters and the various tests are also happening. Coming to the formulation R&D. Now formulation R&D, the many companies across the globe are focusing on the newer formulation. Some are focusing on the oral formulation and some are on the parenteral formulations. The oral formulations are mainly focused on one thing. One is the improved viability, because absorption, the iron absorption, especially from a vegetarian diet is around 5 to 12%, and for maybe from non-veg diet it may be maximum around 15%. So the absorption is a problem. So you can't just load the patient, because if you load the patient with iron, it will cause a GI inflammation and GI intolerance. But still you have to make the iron available, more and more available. So the oral formulation companies are focusing on improving the viability or the absorption of the iron. They're also working on the reducing the inflammation, because now the science shows that when you give a high dose of iron, there is a lot of enterocyte, the GI mucosal inflammation, which actually further hampers the absorption. So this is one of the areas. New molecules are showing interest. Sucromonial iron is showing much interest, or the ferric maltol is showing interest in that. On the parenteral side, the formulation R&D is some companies are focusing on the parenteral iron. So the main focus is the reducing the side effects in terms of vasculitis. So actually the focus is mainly happening on the molecular weight. So low molecular weight iron dextran or maybe iron sucrose are getting developed. There are also monophor ions, ferric ions are actually getting developed, which are actually single dose therapy. So you may not require a daily dosage or the maybe weekly doses of that. The single dose therapies are also getting developed. So this is from the formulation R&D, and the industry is working on that. The clinical research development is also happening, and various regimens are getting tested. And this is not only for the treatment per se, but also for the at the population level, for the prevention purpose also. Regimens will be helpful. So instead of a daily dosing of say 100 or 200 milligram of ferrous sulfate, the low dose iron regimens are getting tested. They have shown very good results. Alternate dose regimens are happening, and at a restricted clinical studies, they are showing very good promising results. So this is actually happening on the R&D front. Coming to the policy shaping or the market shaping, or the protocolization or protocol development of the iron therapy at individual level or the hospital level, I'm aware of few countries, South Asian countries and the Southeast Asian countries. They are actually separating out the frank iron deficiency anemia to iron deficiency status. Okay, so iron deficiency erythropoiesis. So at the community level, they are considering a protocol or the intervention, not only not considering the hemoglobin value, but on basis of the MCH, MCV and MCH values. So this will, although the specificity is not very high compared to hemoglobin, but it gives a decent specificity of 65%. So it is a decent specificity correlation. So they are developing the protocol of individual intervention at MCV, MCH values. At a hospital level, what is happening is many hospitals are broadening the target group. So the problem with iron deficiency is most of the countries and most of the medical faculty is mainly focusing on the maternal and child outcomes on the pediatric iron deficiencies, but the adult group is getting neglected out. There are many patient groups like your CKD patients, like the patients suffering from inflammatory bowel disease or high inflammatory conditions, ICRP, like onco patients or the patients requiring erythropoietic agent. These are the special groups which also need a good iron supplementation, not only for the to halt the progression of their disease, but also to have a better life. So at hospital level, I'm aware of the development where the KDOKI guideline, which was a guideline for CKD management, they have actually lowered the intervention of iron from a hemoglobin level of 11 to 9, and this was also mainly based on the current available data. So the guidelines and the protocol development at the community level and also at the hospital levels are happening. The third
Right. So,
aspect, yeah, I'm
yes, I
just
will,
2 minutes, just
yes,
2 minutes. So
right.
last aspect is, as we all know that without behavioral change and without the consumer, end consumer is convinced, nothing happens. So the awareness and availability also making a actually impact, and companies are working on that. Dr. Madan said earlier, and actually she appealed to the IDA Mumbai chapters to go in interiors of Maharashtra. I know in Tamil Nadu and West Bengal, they have actually developed a system where the PSC, public primary healthcare centers, are also now equipped with the nutritionists and dietitians. So I think the things are happening, and I think let's hope for the best.
Right. Thank you, Dr. Ganesh. That was exhaustive. Dr. Prema, thank you very much for your patience. But as we move to the adult population, and taking it from where Dr. Ganesh left, how important are iron studies, or just a simple CBC with hemoglobin would be good enough for um, anemia detection in
Yeah,
clinical?
like basically a good CBC with your indices properly calculated is good enough. But to that, we often add a ferritin level. Look, I am an endocrinologist and we deal with anemias, not just of nutritional variety, but also in type 2 diabetes, there's an element of inflammation. In thyroid disease, you could have anemias because of achlorhydria, because of autoimmunity to the vitamin B2, to the intrinsic factor, and therefore malabsorption of B12 and associated autoimmune hemolytic anemias. So just sometimes we might find it necessary for us to do a ferritin and a transparent saturation to confirm our diagnosis, even though a good CBC-SR would put us on track by and large.
Great. Yeah, because that's a question which is very confuses a lot of dietitians too, that whether we should be only interpreting the CBC or we should be also needing iron studies all the time. Thank you
No,
for that.
so basically, Niti, what I should say is that you should look at the clinical situation. I mean,
Sure.
the patient as a whole matters. So,
Yeah,
like,
not just the
basically, you
numbers.
start with the basics and then go on to your numbers.
Sure. Perfect. Professor Elizabeth, with mothers moving from breastfeeding to cow's milk, is the iron intake in late infancy, that is 6 to 12 months, is that a concern for you?
Definitely, that is a big concern. If you look at the NFHS 4 data 2015-16, and we see that the maximum iron deficiency anemia or nutritional anemia is seen in the age group 6 months to 60 months, that is up under 5. up to that. And in the lactating mother also it is as high as 58%. That is the highest. And we know that a baby, when the baby is born, the baby is supposed to have a lot of iron stored. And with that, the baby is supposed to manage up to 6 months. And we know that milk is not a very good source of iron, but from whatever little iron is there in breast milk will be absorbed. That is our hope. And if you look at the global scenario, if you look, they will say that exclusive breastfeeding is a risk factor for iron deficiency anemia because they all give the fortified milk. But our population may not be getting the fortified milk. They may be just moving to cow's milk, raw cow's milk, and where the iron absorption is very less. So after 6 months, when the iron stores are gone, they have to depend on the food. And you know the weakest link or the bottleneck in IYCF, infant and young child feeding, that is during the first 1,000 days of life, is the complementary feeding. In fact, we did a small study among infants beyond 6 months, and we found that the anemia prevalence was more when the babies were not exclusively breastfed for 6 months, and in the control group who were more breastfed, they had less anemia. And we know that if the prevalence of anemia in any population is more than 40%, it is a public health problem. And we are far ahead of that. And we have not been doing well. For the last several years, we have been giving the IFA supplements. So now we have the Anemia Mukt Bharat, that is the new version of the National Iron Plus Initiative, the weekly iron folic acid, everything put together. It is a life cycle approach. It is called a 6 into 6 into 6 strategy, where there are 6 beneficiaries, 6 goals, and 6 interventions that are planned. And in that, from 6 months onwards, every baby has to take bi-weekly iron supplementation, that is 1 ml, 20 milligram of elemental iron and 100 microgram of folic acid bi-weekly up to 5 years. And then 5 years onwards, the junior will start. Then after say 10 years, the weekly iron folic acid will start. And women in the reproductive age group, 15 to 49 years, weekly iron folic acid. So it is a life cycle approach they are planning. And instead of the 100 days of iron for the pregnant and the lactating, now it is 180 days. That is lactation period is 6 months, 180 days. So 180 days has to be covered. And during pregnancy and lactation, it is daily iron. Otherwise, bi-weekly is for the 6 months to 59 months. And after that, it is weekly iron. And one more change has come is that now they are recommending delayed cord clamping, 1 to 3 minutes, or physiological cord clamping, that is till the pulsation stops. That will give lot of iron to the baby. Then biannual deworming is coming up, and also cooking one item a day in iron cast iron pot is also being recommended. And it is I hope that these changes will have some impact in reducing the iron anemia load. And another thing is that from 100 milligram of elemental iron of that entry coated tablet, now the recommendation is to come down to 60 milligram of sugar coated. And we know that the tolerable upper limit is fixed somewhere at 60 milligram.
Right. I think that was an absolutely comprehensive answer. Thank you, Professor Elizabeth, for that. Switching gears, talking about adults, Dr. Prema, since you worked on subclinical hypothyroidism, what is your take on iodized salt? And would a close look at other micronutrients, such as dietary selenium intake, also help, especially during this stage when patients are not put on thyroid, very often not put on thyroid replacement therapy? So the iodine intake, dietary selenium intake, is that something we need to closely look at in this population? Dr. Prema?
Am I audible?
Yes, you are now.
Yeah, okay. So basically, the concept of iodine prophylaxis came up as prevention of your iodine deficiency disorders, which can sort of vary or range from simple thyroid dysfunction down to neurologic disorders and cretinism. That leads a whole burden, a socio-economic burden on the country. And that was therefore the reason why we took up this project of iodine supplementation. And I think that's one of the most successful preventive health measures that probably our country has undertaken. Obviously, there are going to be some trade-offs when you have a situation like this. Suppose I have a situation where I get an increased iodine intake, and the underlying thyroid is normal. There would be a stunning of the thyroid. That would be a reduced hormone production and release, which we call as the Wolff-Chaikoff effect. So transiently, these people would be like going into hypothyroidism. Now, after the introduction of iodine prophylaxis, we also have situations where we may be overdoing the iodine supplementation. And we must remember that most iodine deficient thyroid glands usually enlarge, they become what we call as a goiter. They could be nodules, and they could be multiple nodules as well. And some of these nodules may be autonomously functioning. So therefore, there would be a situation where this excess iodine is actually actively utilized by the thyroid gland, and that can lead to what we call as an iodine-induced thyrotoxicosis. Now, if the thyroid gland is able to recover from this excess, that means escape from this excess phenomenon, this toxicosis may be transient, but otherwise it could sort of go on for a long time. Now, we also have to remember that when I'm giving iodine, it is a cofactor in your thyroid peroxidase enzyme, the enzyme which is responsible for the synthesis of the thyroid hormone, and it also induces an immune response in the thyroglobulin, the molecule which sort of binds to iodine and keeps it in its stores. So this again can lead to an increased prevalence of autoimmune thyroid disorders. But as a study from AIMS has shown, compared to the benefits that we've had with iodizing our salt and using iodine prophylaxis in terms of outcomes where there is true iodine deficiency, the increase in autoimmunity or iodine-induced thyrotoxicosis or a mild transient hypothyroidism is only of the order of 4 to 5%, and these are eminently treatable conditions. So, like, therefore, these dangers or these pitfalls occur. And another thing that we should remember is we require about 150 micrograms of iodine as prophylaxis. It's only when you cross the 300 microgram limit that you're going to get into these situations. So previously they used to just monitor the existence of goiters or the absence of goiters and probably your other development. Today, they're actually scientifically estimating urinary iodine excretion and determining whether you're iodine deficient, sufficient, or you're overdoing the iodine act. And that's something that we should sort of be monitoring when we are especially dealing with populations that are not tremendously iodine deficient. Now, when we come to selenium, selenium is one mineral which is actually incorporated into polypeptide chains as a selenoprotein. And this selenoprotein is part of a huge family which comprises glutathione peroxidase, thioredoxin reductase, which is your this thing, and iodothyronine deiodinase. So this actually has an impact. Selenoproteins actually has an impact on the functioning of the thyroid gland. And especially in the situation of chronic thyroiditis, the selenoproteins are impacted. And this sort of ultimately does lead to destruction of the thyroid gland. So yes, when we're talking in terms of autoimmune thyroid disorders, we're talking in terms of replacing selenium and saying that a dose of about 200 micrograms of selenium per day does reduce the intensity of the autoimmune response that the thyroid gland might face. And in the very early phase of thyroid eye disease also, selenium may perhaps have a protective effect and prevent the progress. So yes, iodine and selenium are important nutrients, micronutrients, and we need to sort of use them judiciously to ensure that you have a benefit towards the patient and don't have too much of a risk.
Great. That's perfect, Dr. Prema. In fact, before we start taking audience questions, last question for Dr. Joshi. Should we supplement every individual with serum B12 levels less than 300 without any visible symptoms? And on the other side, we see a lot of patients whose levels are above 2000. Should we allow them to continue taking the B12 supplements because they are taking perhaps a couple of different multivitamin supplements and they're also taking a B12 supplement on its own? So what is your take on this? There are two different extremes that we see in practice. Dr. Joshi? Is Dr. Joshi around? Can you hear us?
Sorry, can you hear?
Yes, please. Yeah.
Yeah, as I said, that the vegetarian population definitely is deficient in vitamin B12, where supplementation is definitely recommended. But as I mentioned earlier, we cannot go overboard on any of the micronutrients. So there are some people who are taking large amount of vitamin B12 injections also. So that too needs to be monitored, just as you would monitor for maybe zinc, selenium, or any of the other micronutrients. Vitamin B12 also, I would suggest that one needs to take the optimal dose and not go overboard on any of the micronutrients.
Right. So if somebody comes in with a level of 2000, we would ask them to discontinue.
Yes, yes.
And at the same time, if somebody is less than coming with less than 300, would we supplement them without?
See, because before you start any kind of supplementation, you have to know about the other constituents of the one carbon cycle. That means namely folate and homocysteine levels. So only after you assess all the different components, I would suggest that one goes in for any kind of supplementation and not over the counter. It cannot be just a random vitamin B12 supplementation. It should be closely monitored.
Sure. Right. I'm going to start taking questions from audience because there are many.
Hello.
This
Yeah.
question is for
Hello,
Dr.
Niti.
Yes.
Hello. Yeah. I just want to just comment one additional as a dietitian here. After
Yes,
as we're talking
sure.
about all supplementation and all that, but I'll tell you there is as what our Soroshan said, ki they are doing in the rural areas. There's so many things they explain them. As it's really true, and I'm here totally agree with Elizabeth ma'am and Sadhna ma'am. See, as when I see personally in our hospital, public government hospital, we what we observe right from the low socioeconomic class to upper whatever, but then they lure towards packet foods and fancy foods or biscuits, and so many things are so much into attraction is there in the even the lower socioeconomic class and upper. So when patient comes with the malnourishment, though the group is children, infant, toddlers age, or the pregnant women, or even the normal adolescents, I usually find that they are having as we are talking supplements, but through food there is so much to do. When we take detailed assessment, when we do nutritional assessment and we take detailed dietary recall, we find that there are so many things which they can really do, because our India has got so much food diversity, and there are every religion, every community has so many various combinations of recipes with including all balanced nutrition. So there is a lot can be explained to each and every female, and we can improve on their status with the food. As ma'am said about the omega 3 supplement, she rightly said, when we usually tell them about supplements is the one part, but then through food like LNA sources, even omega 3, there are so many unnecessary myths about specific food. So there is a lot can be explained to them, right from in every group: whole grain cereals, vegetables, fruits, combinations of multiple, with cereals to with the dairies, or cereals plus combination, cereals with vegetable combination. In every region, we can explain them a lot, and we
Yeah,
can
so
definitely
supplementation
improve.
is not the
Yes,
only
yeah.
answer. Yeah, we need to first work on
Even
food
in LNA, we
diversity and
simple, they
local
say
choices.
pumping seeds, or flax seeds, or even the normal,
Yes.
as walnuts are very costly. We then tell them the sunflower seeds. There's so much. Even simple fennel seeds has good calcium and magnesium and fiber and so much. So
Sure.
there's lot done in the intervention, nutrition intervention.
Absolutely, absolutely. We have dietitians have a big role to play. This question
Yes,
is
yes,
for
very
Dr.
much.
Prema ma'am, Dr. Prema ma'am. Conditions which show low ferritin levels like ADHD, should we still supplement iron in these children? How can one work on low ferritin levels?
Um, Ferritin is, on the one hand, ferritin is supposed to be a marker of iron deficiency. But like you rightly pointed out, there are lots of conditions wherein you have high ferritin levels and low ferritin levels. There, I think you should be looking at your absolute iron levels and your transferrin saturation. That will give you an idea as to whether this ferritin is being, a marker of another condition, an inflammatory condition or something of that sort, versus whether it's a marker of just iron nutrition. So I think therefore your indices then would matter, definitely would matter.
Right. I see a lot of questions here which luckily have been answered through the session. Is there any correlation between micronutrient deficiency and hemoglobin levels in males and females? I think we had an excellent discussion on this. Veena Ladwani, how important selenium is and relation with thyroid gland function? What dose is recommended and availability in market? We did discuss selenium for hypothyroidism. Sadhna Joshi ma'am, what should be the salt recommendation, iodized or uniodized to hypothyroidism? Again, Prema ma'am did touch on this. Micronutrient deficiency map food system pathways from crop to household levels, its social, economic, and agricultural drivers. How to combat malnutrition in rural infants, please suggest. I think, again, we had an excellent discussion on this. Is there any correlation between micronutrient deficiency and poor food absorption leading to gastric issues? Dr. Prema, would you like to take this?
You said micronutrient, sorry, the question was micronutrient deficiency and gastric issues, right?
Yes. Does it lead to poor food absorption and gastric issues?
Okay, like basically, I think the other way, probably in my experience, it is those that have an inflammatory bowel disease or malabsorption. They are the ones that are more likely to be, associated with nutrient deficiencies, micronutrient deficiency especially. In the situation of zinc, I have sort of come across references that zinc deficiency can be associated with GI problems. Also, micronutrient deficiencies are seen when we do total parenteral nutrition or intravenous nutrition. That is a situation. But a micronutrient actually causing a GI disease is something, I'm sorry, that I haven't come across. If anybody else in the panel would want to say something. I think it's the other way around. GI disturbance, micronutrient deficiency.
Can I add?
Yeah.
That is the problem. Usually we say that so much of iron is being pumped in, but anemia is increasing. One of the reasons they say is that our gut is having so much of inflammation that the iron is not absorbed. And another thing we have seen even with our own colleagues was that they were not improving with iron. They were becoming iron refractory. It is not because of genetic causes. And now we understand that H. pylori infection is in the upper gut is one of the reasons why the iron is not bioavailable. So we may have to treat that wherever it is relevant. One course of H. pylori treatment, followed by that the iron may be absorbed. And we were speaking about, another thing is some of the drug interactions. For example, zinc and iron compete for the same pathway. And we always say that vitamin C will increase the iron absorption, but the ratio has to be 2:1, like that, vitamin C to iron. Then anti-nutrients, for example, we say amla has lot of vitamin C, but it has got a lot of polyphenols, which is an anti-nutrient to iron. So that may not work. So such things, phytate also, phytate, anti-nutrients may not work. That is something which we will have to think about.
Yeah.
And diversity is another thing. So we have to tell them about that. In small children, it is not possible for dietary diversity, but of course, at least in adolescents and pregnant mothers and all, we must be promoting that dietary diversity for the micronutrients.
Yeah, and there's one thing that I'd like to add, Niti, is that in the case of thyroid, hypothyroidism, we give thyroid replacement therapy. Very often people are on polypharmacies and the commonest thing they take is iron and calcium, and they think, oh my God, what difference does it make? I'm in too much of a hurry. Let me finish all my medications at one go. That's one place where malabsorption occurs. And the second thing about overdoing nutrients, we have to, like Madam Elizabeth said, remember that lots of these nutrients compete for the same pathway on the one hand, and one nutrient might actually not be complementary, but might actually, like for example, if I overdo my zinc, I might push down my copper. So that's something that I should bear in mind. Never overdo your nutrient supplementation.
And yes, like a lot of people take iron, calcium, and the thyroid replacement, together all in the morning. They just want to finish it all off. So you're kind of completely negating the medical treatment, the pharmacotherapy. Right. For want of time, I think we will have to bring this extremely riveting and interesting discussion to an end. I would sincerely like to thank all our panelists who contributed immensely, and I think made it a very, very enlightening discussion for the audience. Thank you, Dr. Prema. Thank you, Professor Elizabeth. Thank you, Dr. Satna Joshi. Thank you very much, our own Safal and Roshan. And of course, Dr. Ganesh for giving us time on a working day. I know we are all working virtually, but yes, still, thank you so much for your time. I will hand over to Megha to take the proceedings further.
Thank you, ma'am. It is an honor to propose a vote of thanks for today's seminar. On behalf of IDA Mumbai chapter, I thank the entire panel for sharing their experiences and insight with us. We are really privileged to have all of you over here today. I thank Neeti ma'am for conducting a beautiful panel discussion. Once again, thank you, Yajnik sir, for his informative presentation and setting this webinar for such a great panel discussion. I would like to thank Hatsa for the collaboration with IDA Mumbai chapter, without which this webinar would have not been possible. Thank you, Mr. Ajit Singh, President of Hatsa. Thank you, Dr. Vaibhav Kulkarni, for his wonderful opening remark. I thank our very own Madam Ma'am for her enlightening talk as always. Thank you, Zamrita Ma'am and Jaishri Ma'am, the convener and co-convener of IDA Mumbai chapter. Thank you, Shilpa Ma'am, for the wonderful Q&A session on 25th that was conducted. I take this opportunity to thank the entire LEC committee for giving support throughout. Special thanks to the convener of this program, Ms. Ruby Ma'am, for managing this webinar together with me. Our all-rounder team member, Sukada Ma'am, for her throughout support in all the webinars and encouragement. Our very encouraged girls, Kasturi, Dev and Prachi Sautekar, for their coordination for all the webinars. Lastly, I would thank all the participants for the active participation. Also, we have, as Ruby ma'am mentioned, we have some participants from across 15 countries apart from India. Few are from Nigeria, Dubai, Tokyo, Peru, London, etc. So I thank you so much. Thank you everyone for making this webinar a great success. Thank you so much.
Thank you very much.
Yeah, and now without a delay, I call upon Mr. Narayan Sainathan, Honorary Treasurer of Hatsa, to give away a formal vote of thanks.
Thank you, Megha. I think you have covered and thanked most people. It's been, of course, a definite privilege to have attended this webinar, and I must definitely say it was a very, very informative and a topic that has not really been touched on by people. So I'm sure it's been a real success for most of the attendees on hearing this topic. Yes, of course, I would definitely like to thank Dr. Jamrut Patel, Dr. Ruby Sound, Niti, and all of you for having made this webinar a complete success. A lot of work, of course, has been put in by the entire Secretariat of IDA as well as HADSA to ensure complete attendees for this webinar, and I know that it's quite a task to ensure that you have a lot of people coming in. Last but not the least, of course, all the participants from all over the world who have attended, a big thank you to all of you for ensuring complete success. I would also like to take this opportunity to inform you all, we have one more webinar coming up that is organized by HADSA. It's being presented by Dr. B. Shashikaran on nutraceuticals building consumer confidence with scientific reasoning and evidence. This is going to be held on the 30th of September at 4:30 p.m. If anybody does wish to attend this webinar, you need to write into us on admin@hatsa.com. I thank you all once again, and thank you very much for attending this webinar.
Thank you, sir.
Thanks.
For all the participants over here, I would like to announce that we are circulating the feedback form both on YouTube comments and on in the chat box. I request you to fill the feedback form within 24 hours, after which the responses will be closed. And after filling the feedback form, only we will be distributing the certificates within 5 working days. Also, I would like to announce the upcoming webinars, which is on 4th October and 3rd October. On 4th October, it is on pain management. And on, yeah. And on 3rd October, it is a NutriFam quiz for all the family members. They can join.
Wait up 1 second.
Yeah.
Just stop first. Okay, if I could just give a heads up, the session on the 4th is on back pain, and we have a very good speaker who's going to cover how to deal with back pain for general population. So we request you to circulate the session link to all your friends and family members who can benefit from this session. And another surprise session on 3rd. Over to you, Megha.
Just display the.
में ये दूध पीना जरूरी है क्या? इससे क्या? दूध पी लो, आज ही आपके बाल काट के रखो। अम्मे, ये दूध पीना जरूरी है क्या? इससे क्या मिलता है हमें? हाँ पी ले बेटा, मैं भी ये फल बहुत मुश्किल से खाती हूँ। तेरी माँ कहती है दिन में 2 फल खाया कर। हाँ बेटा, milk is good in protein and calcium. हमारे बोन इससे स्ट्रॉन्ग होंगे and it is good for your overall health. दादी को तो ये पता ही है ना। ये कहाँ से सीखा आपने? इसके बिल्डिंग का ग्रुप जो है। नहीं बाबा, I read it on IDA, मुंबई चैप्टर, FB पेज पे। IDA? Yes, IDA, Indian Diabetics Association, Mumbai chapter.
Follow us on Instagram, like us on Facebook, and subscribe to our YouTube channel for evidence-based scientific information.
And guess what?
Now your entire family can join us on a fun quiz on nutrition. We are going live on 3rd October at 5 p.m. on IDA Mumbai chapter Facebook page. Come join us and win exciting prizes.
We look forward for the active participation from all the family members out there. Thank you so much.